next up is Dr. Deb Stein. I'm going to read this whole big important thing of how great Deb is. No? Okay. Deb's professor of surgery at University of Maryland and director of adult critical care at University of Maryland, not just at the Shock Trauma Center, but for all of critical care. She's done a lot of work, is well-funded in the space of VTE, is heavily involved in research through the American College of Surgeons, the AAST, and is the current East president. So another one of my bosses. Thank you very much. Deb is going to talk to us today. We changed the title a little bit. We were hoping to have some data from a really amazing study that she and Bob O'Toole are running, but it's not quite ready for presentation. So we changed the title a little bit, but hopefully you're still going to tell us about it even without the data. So Deb Stein.
I'm bringing my tablet up because I'm 100% sure I won't be able to see that monitor, so just in case. All right, well, good afternoon, everybody. As the second to last speaker of the day, I will go through some of this relatively quickly because John, who's following me, is going to talk a little bit more about aspirin for VTE prophylaxis, so I don't want to steal any of his thunder. So I sort of modified the name of this talk as well, the aspirin study from ADAPT to prevent clot, and I'll kind of talk to you about what that means. I do have one disclosure. I am funded, as Dr. Hout said, by PCORI for this randomized controlled trial that I've been fortunate enough to collaborate with my colleague, Dr. O'Toole, on for the last several years, but I have no personal financial disclosures. So this conversation all started with a discussion amongst myself and one of our orthopedic colleagues, Dr. Ted Manson, who's a good friend of mine. We, by the nature of the way kind of things are set up at the Shock Trauma Center, a lot of the patients who wind up with hip arthroplasty or hip fractures stay on the trauma service just by the nature of design. And so what we noticed was that orthopedic residents were coming in and saying, Dr. Manson doesn't want this patient on Lovenox, he wants them on aspirin. And I was like, you all know that Lovenox is better for trauma patients. And so patients at a trauma center, therefore they're a trauma patient, therefore this is what they should get. And so this kind of kept happening, and it was starting to branch out to the acetabular fractures and a little bit of pelvic repair. And, yeah, the orthopedic guys, they don't want the patient on Lovenox, they want the patient on aspirin. And, of course, they should know better, right? We know that Lovenox is the best option. We know that it's associated with the lowest complication rate. So Ted, of course, very appropriately was like, well, why don't you look at the literature? And I was like, oh, look at the literature. There's literature on this. And, yeah, there actually is. Again, this is largely the arthroplasty literature, which I'll talk about. But there is actually literature that talks about low molecular weight heparin being associated with increased complication rates. This particular study is about Coumadin versus aspirin. And you can see the numbers there with respect to wound-related complications. Again, this is following arthroplasty. But you can see that Coumadin is associated with a higher wound complication rate. This is a total of 290 consecutive patients who were treated with a 10-day course of Lovenox per the ACCP guidelines. And you can see minor complications in 9%, DVT and 3.8%, non-fatal PE and 1.3%, but relatively high complication rates. And that bottom line there, return to the operating room for wound complications occurred 3 times more frequently with the use of Lovenox than in a previous study the same group had done using warfarin. So, yeah, there is something in the literature, suggesting in the literature, that low molecular weight heparin may be associated with an increased risk of wound complications. Well, what about, is aspirin actually any good at preventing VTE? Well, early studies, this is back in 1992, if you look at on the right-hand side there, no prophylaxis, 25% incidence versus 20% incidence in aspirin, so not a huge risk reduction there, we can all agree on. But there were a couple of studies that demonstrated some early benefits. So this is one study, 25% of patients who received antiplatelet agents versus, again, controls who received no prophylaxis, 34% had a DVT. So some suggestion of benefit there. Again, that's back in 1994. Another study in 2000 that aspirin did, in fact, reduce the risk of PE and DVT by at least a third. So again, some data. But as Dr. Gertz and I were talking about earlier, I think what the really key thing here is those early studies, 94 and 2000, we take care of patients overall vastly differently now than we did back then. And so when you think about the multidisciplinary clinical care protocols, the pain management protocols, early mobilization, the overall risk of VTE has just changed over time, appropriately so, because hopefully we're just doing a better job of taking care of people overall. Well, then there were a series of studies, again, this is in the arthroplasty literature, that demonstrated that, you know what, aspirin actually does seem to prevent VTE. And so this is one study, this is 93,000 patients observational study who underwent knee arthroplasty at 307 U.S. hospitals. You can see 55% received warfarin, 40% received injectable agents, 5% received aspirin, so a very low number. After adjustment for patient hospital factors, the patients who received aspirin had a lower odds for thromboembolism compared to warfarin and equivalent outcomes when compared to injectable products. So kind of some suggestion there of benefit. Subsequent to that, 2012, this is again 1,568 consecutive patients, again arthroplasty, knee and hip, who some received aspirin, some received Coumadin, some received multimodal therapy, and you can see the rates there of VTE, PE, proximal DVT, and distal DVT were really equivalent in the aspirin and the Coumadin groups. Subsequent to that, this is a study that was a multicenter randomized controlled trial that was looking at non-inferiority of aspirin, 778 patients. Again, this is arthroplasty, 28 days of dalteparin following a 10-day course of in-hospital therapy versus aspirin. And what you can see here is that the study was in fact halted because of difficulty with enrollment, but they were able to demonstrate non-inferiority of aspirin over dalteparin in this one study. And then I think this is the last one. Yes, this is in 2014, single institution, 29,000 patients underwent total joint arthroplasty. They did a 3-to-1 and a 5-to-1 analysis. And you can see there, again, there was actually a reduction in VTE events in patients who received aspirin when compared to those patients who received warfarin. So certainly the arthroplasty literature is pretty compelling that there is probably, at minimum, non-inferiority in the modern era, the way we currently take care of those patients. That led the American College of Chest Physicians, as well as the American Academy of Orthopedic Surgeons guidelines that Anna presented to us earlier, to basically say that, yeah, aspirin can probably be used in arthroplasty patients. So what started as a discussion turned into a really rich and really wonderful collaboration between our trauma surgeons and our orthopedic surgeons. And we decided to say, we said, if we're going to give aspirin to people who have acetabular fractures, who are trauma patients, not just arthroplasty patients, instead of giving them what we all consider our standard of care, low molecular weight heparin, we're going to study it. And so what we did was we actually decided to do a randomized controlled trial. The first order of business is obviously acute acronym. So we came up with a different approach to preventing thrombosis. There are like 19 trials that have the acronym ADAPT, though, so it's kind of useless, but it made us feel better. Second order of business was to establish our primary outcome metric and methodology. And what that led to was a really, really innovative, and I freely admit the methodology behind this is not my forte. If you have questions about it, please direct them to Dr. O'Toole. But it was a discrete choice experiment, which is something that's done in healthcare economics to compare different products and how people feel about different products. What basically it was there are quantitative techniques used to measure individual preferences in a variety of healthcare settings by administering surveys that ask individuals to choose between two options based on hypothetical scenarios. The options are then described with a fixed set of attribute levels that vary in each scenario, and the data can basically be used to determine what's of relative importance to consumers, to patients. So we did this discrete choice experiment in our level 1 trauma center, 232 patients. The primary, secondary outcome measures were relative preferences and trade-off estimates for a 1% reduction in complications with a oral agent versus an injectable agent. And what we found was, not surprisingly, that patients preferred oral tablets over subcutaneous injections. Okay, we got that. But as we started to give them complications, bleeding, wound complications, VTE, and then death, what we found out was, and we laugh about this because I don't know why we were surprised about this, patients really, really don't want to die. They'll accept a couple shots if it means they're not going to die, right? Which sounds ridiculous until you actually are surprised by that. We're like, well, they hate their Lovenox. Well, they hate dying more. We found that out. So that led to this composite endpoint that we used for this randomized control trial. It was an open label randomized trial, adult patients, again, limited to our level 1 trauma center with an operative extremity fracture or a pelvis or acetabular fracture. Patients were then randomized to receive 30 BID of low molecular weight heparin versus aspirin, 81 milligrams twice daily. The regimen we can debate. And the bleeding outcome was a composite endpoint of bleeding complications, deep surgical site infections, DVT, PE, or death within 90 days of injury. And what we did was we weighted those study outcomes in our for this composite outcome measure for the relative significance to patients, meaning death was weighted much higher than a bleeding complication. And what we found was there were 18 different combinations of outcomes that were experienced by our patients, one DVT and one bleed, fatal PE. And what we found was that 99 patients in the aspirin group, so 60%, and 98 patients in the low molecular weight heparin group, or 59%, were event-free within 90 days. And basically, we were able to demonstrate, not powered for mortality or anything, but for our composite endpoint, non-inferiority of aspirin over low molecular weight heparin and non-inferiority of low molecular weight heparin over aspirin. We then did a couple of secondary analyses based on these data. We wanted to get at this issue of compliance, and specifically we wanted to look at both inpatient compliance and outpatient compliance. So we did look in this study, this was inpatient compliance, and again, these were patients who were enrolled in a clinical trial. So this is not necessarily, before Elliot jumps up and down, this is not necessarily your average patient who's sitting in our hospital today, right? These are patients who are being closely watched, and if anybody knows Dr. Hack, who was our research resident who did this, the pitfall that she was, if the nurses didn't give the prophylaxis, they heard about it from her. So we had our own little mini intervention going on. But basically what we found was, yeah, there actually wasn't a difference in missed doses. And in fact, we were pretty surprised to see 41% of patients missed an aspirin dose, 43% of patients missed a low molecular weight heparin dose. The mean number of missed doses was 0.6 versus 0.7. And so basically, and almost 60% of patients didn't miss any doses at all. Again, but these were patients who were enrolled in a randomized controlled trial and were being very closely watched. We also looked at outpatient compliance to see if that would be different. We basically, if patients were deemed appropriate to be sent home on a prophylaxis per standard of care, per our current standard of care, they were sent home on whatever they were randomized to. And Bryce used the MMAS, the Morisky medication adherence scale, to then evaluate what patients' adherence was with either aspirin versus low molecular weight heparin with the multivariate logistic regression. 150 patients were followed up, included the questionnaire, 64 on low molecular weight heparin, 86 on aspirin. And the as-treated analysis showed that the adherence was actually very high, 7.2 out of 8, and similar for the two regimens, 7.4 versus 7.0. So adherence was actually not statistically higher. Patients, however, on low molecular weight heparin were more likely to feel hassled by their regimen. And if you looked at variables that were associated with lower adherence, taking low molecular weight heparin was associated with slightly lower adherence, and again, in a multivariable model, having to self-administer to the point that Dr. Malhotra made of having to self-administer Lovenox, male sex and younger age were all associated with as slightly lower compliance. So we basically said, well, what are we going to do with this data, or these data? And we decided to, again, do a multicenter trial, and we decided to do a randomized, controlled multicenter trial. We, of course, needed a cute acronym. I don't know who takes credit for this one, but Prevention of Clot in Orthopedic Trauma Study, or the Prevent Clot Study. Our second order of business was we were very fortunate to have incredibly smart collaborators like Dr. O'Toole and his colleagues and the folks over from Johns Hopkins. We were able to successfully secure funding from PCORI to do a randomized multicenter controlled trial. This was run out of the University of Maryland Department of Orthopedics, as well as the METRIC Consortium that's over at Johns Hopkins. The plan was over 12,000 patients to be enrolled at one of 21 participating centers. We did something that I think was kind of a little bit unique. At each of these centers, Bob made a list of really high quality orthopedic trauma research facilities, and I made a list of really high quality trauma center research facilities. Fortunately, those two lists looked remarkably similar, and therefore we were able to come up with 21 centers where we had an orthopedic PI and a trauma surgery PI at each institution that collaborated together. The inclusion criteria for the study, they had to be over 18 or over, have a planned operative or non-operative pelvis or acetabular fracture or any operative extremity fracture proximal to the metacarpals or carpals, and receiving VTE prophylaxis per standard of care, meaning I, as a trauma surgeon, or Dr. O'Toole, as the orthopedic surgeon, deemed the patient appropriate for prophylaxis. They were then considered eligible and were allowed to be randomized to one of those two arms of low molecular weight heparin versus aspirin. Primary outcome was an all-cause mortality. Secondary efficacy outcomes included all-cause specific mortality, non-fatal PE and DVT, and then, of course, safety outcomes of bleeding complications, wound complications, and deep surgical site infections. And I'm really excited, but As Dr. Hout said, I don't have any data, I don't have any outcome data to share with you today. Hopefully very soon. The study has concluded. We did enroll over 12,000 patients. Extremely proud of the work that was done. And so for those of you who collaborated with us, thank you. Hopefully we will have results to share with you very, very soon. And I'm happy to answer any questions except what the results of the study were. Thank you.
Dr. Stein, I have two questions, actually. One, do you have biologic data? Did you collect blood samples on these patients?
We did not. Pragmatic design, funding, et cetera, et cetera.
Totally.
It would have been, yes, we would have loved to.
And the second question is this isolated orthopedic trauma?
Nope. This was, the patient had to have an orthopedic injury to be included, either operative or non-op pelvis or acetab, and they had to be deemed appropriate for prophylaxis. So if your institution says, I don't ever give my TBI patients prophylaxis, they were excluded. At our institution, where we give prophylaxis to patients with brain injury after 48 hours, they would receive whatever they were randomized to at 48 hours. So there are patients in there who have TBI, there are patients in there who have significant abdominal trauma. There's a lot of them are orthopedic only, but a lot of them are also polytrauma. So we're super excited to look at that group specifically.
So that we didn't control the timing of starting prophylaxis. It was all local protocol.
Yep.
It'll be a great data set to do some secondary analysis on.
So
yeah.
We're looking forward to it. So let us know when you have, once we do the primary analysis, we can do the secondary. But yes, no, we're really excited. And I think that, the key thing about it, there's lots of things you can pick apart about this. Both Dr. Achul and I are sitting here going, should we have done 40 BID? I don't know, right? But we're super excited about the successful completion of a difficult to administer trial, and we really look forward to the results to be able to share with everybody to see if we can improve how our patients experience their VTE prophylaxis. So, thank you all.